disorders of pregnancy. Diagnosis. Before starting my topic, I want to show few pictures taken today morning from our MSc. This is the early morning case received in MICU. Hope you can identify my cases. What case is this? Case of eclampsia. What you are saying there? Mouth glazed. Okay. See, this is the case of eclampsia, her period. This is a smiling, happy face. Who is it? Postpartum eclampsia, post-op. Postpartum eclampsia, and she is a happy smiling face who was discharged after her delivery. This is a postpartum eclampsia case. Why am I showing these pictures? Because hypertension is so common and so neglected disease. As madam said, Bimari, it's really Bimari which ladies are not ready to accept and take treatment regularly and have a regular follow-up. They don't want to be called as a patient, BP patient or sugar patient. That is the main problem with our ladies. So now I'll stick on to my topic. So hypertensive disorders of pregnancy are high blood pressure conditions that occur in the pregnancy. We are dealing with pregnancy. So hypertensive disorders, because we are so concerned, because it is a major cause for maternal, fetal, neonatal morbidity and mortality, complicating about 10% of the pregnancies worldwide. We are receiving almost every day 2 or 3 cases in our MSc because ours is a reference center. So that common, 10%. Okay? Hypertension is a, so this is a 140 systolic or 90 diastolic more based on the average of at least 2 measurements taken after 5 minutes rest, at least 15 minutes apart using the same arm. Okay? What are the physiological changes in blood pressure? What occurs in pregnancy? During a normal pregnancy, because of with the local vasodilators like prostacyclin and nitric oxide, there is a fall in blood pressure due to vasodilation. This actual reduction in blood fall slowly, gradually rises to the pre-pregnancy levels by 36 weeks. But what happens in preeclampsia? Here, in the placentation, the invasion, the spiral arteries are in the fault. What is the fault? Here, there is a fault in the remodeling, where the endovascular trophoblasts fail to enter into the spiral arteries, leading to the narrowing. They don't do vasodilatation. From there, the pathology starts. Here, these are the etiologies. How the pathophysiology develops. What is the pathophysiology in a hypertension woman? The main predisposing factors, which are like patients with already existing hypertension, diabetes, chronic kidney disease, or obesity, or non-modifiable factors like age, race, ethnicity, and all related to their pregnancy complications like multifetal gestation, if they are conceived with the ART or nulliparity, and genetic. It is also genetic, where there are genetic predisposition is found in the very latest studies. There are many immunological modulators also for this pathway and other biological. These all lead to hemodynamic and metabolic changes, which pregnancy adaptation fail lead to preeclampsia. See here you can see the angiotensin, renin-angiotensin stimulation, and all these pathways, angiotensin imbalance, all this is a cell cycle arrest, and these are the inflammatory markers commonly found, which leads to endothelial dysfunction, pro-inflammation and pro-coagulation. What are all the effects of these inflammation on different organs? Here, these are the different organs. On the liver we have impaired LFT or we can see hepatic infarction with hypertension in the blood vessels. We have hypertension, edema, thrombocytopenia, activated coagulation, and DIC, which may lead to venous thromboembolism. Under the brain, cerebral edema, hyperreflexia, eclampsia, breast stroke, vascular dementia. On the heart, if not now, at least in the later stages also they may have MI, PCM, coronary artery disease, and heart failure syndrome. And on the kidneys, glomerular endotheliosis, proteinuria, podocyturia, AKI, which may end up in chronic kidney disease and end-stage kidney disease. And here you can see the placental infarction, placental abruption, that may in turn lead to the small for gestation age and fetal growth restriction. This doesn't stop here itself. This is continued to the generations. This doesn't stop with this baby. Even this is a baby who is born empty earth, it will transfer the same thing to the next generation. There is a possibility. There are so many hypotheses claimed. Now I will come to my topic, classification of HTP. As per ACOG 2020, here are the different terminologies: chronic hypertension, preeclampsia and eclampsia, preeclampsia superimposed on chronic hypertension, gestational hypertension, which is transient, and it has to resolve in 12 weeks postpartum. Then only it is called as gestation. This is ISS HP classification, International Society for Study of Hypertension in Pregnant Patients. This is latest classification 2023. Here few things are added. The same thing, hypertension known before pregnancy or present in the first 20 weeks. Chronic hypertension. Again, this is essential and secondary. White coat hypertension, masked hypertension, hypertension arising de novo at or after 20 weeks, transient gestational hypertension. Again, the same preeclampsia, de novo, superimposed on chronic hypertension. So, a brief explanation about the classification. Hypertension pregnancy may be chronic. So, that is predating pregnancy or diagnosed just before 20 weeks of pregnancy or de novo, that is either preeclampsia or gestational hypertension. Chronic hypertension why it is important? Because it is associated with adverse maternal and fetal outcomes and is best managed by controlling maternal BP. This can be managed by early diagnosis. Okay? See, so that we can achieve very good fetal growth and we can avoid other maternal complications. What is white coat hypertension? White coat hypertension is when we see patients in OPD, suddenly they have a sudden rise of BP. Many times we encountered this. My PGs all, we have faced the same thing. Again, the recheck BP after settling her down will be normal. So what is this white coat hypertension? It refers to the elevated BP, but normal BP measured at home will be normal. And this is also a major cause. If this is unidentified, sometimes it may rise, sometimes it may go. This will lead to the unidentified preeclampsia which can deteriorate without warning. Okay? Masked hypertension. This is another form of hypertension. This is still more difficult because patients when they see us, it will be normal, but at home they may have higher BP recordings. So all this can be how we have to differentiate and how we have to evaluate what is the proper BP recording is ambulatory BP monitoring method. The patient is tied to a BP cuff for 24 hours. There are many advances even in the BP monitoring, but this is a regularly followed method. So, ambulatory BP method or automated home BP monitoring is ideal. At least for 24 hours, we monitor the BP, even including during her sleep. What is gestational hypertension? Arising after 20 weeks of gestation in the absence of proteinuria without biochemical and hematological abnormalities. Preeclampsia, it's a complex medical disorder, we all know. So, the same thing. Gestational hypertension, we can define it as a systolic BP 140 mmHg or more and diastolic BP 90 mmHg or more, or both on 2 occasions, at least 4 hours apart, after 20 weeks of gestation in a previously normotensive patient. Preeclampsia. It is a pregnancy disorder which is associated with new onset hypertension and proteinuria. And other signs of preeclampsia may also be present. Here, recent guidelines, they have coined as, even this, PG should know this classification. Early onset preeclampsia, it is less than 34 weeks. Late onset, it is more than 35 weeks. We know up to this, but here we have another criteria of preterm onset, which occurs latest at 37 weeks, and term onset, which occurs at more than 37 weeks. Okay. Again, here the present which preterm commonly. These are the diagnostic criteria of increased blood pressures, as I said before. Sometimes the blood pressures with 160, they present with 160 and diastolic blood pressure of 110 or more. This is severe hypertension. This cannot be confirmed for the first time. We have to serially monitor. They may have the proteinuria, 300 mg or more for 24-hour urine collection, or this amount may be extrapolated from the time of collection, from whatever the time she collects. Protein creatine ratio of 0.3 mg per deciliter or more. Dipstick reading of 2+. Or in the absence of proteinuria, if there is a new onset hypertension with new onset of any of the following like thrombocytopenia, renal insufficiency where the serum creatinine levels are more than 1 mg per deciliter, if there is an impaired liver function test like elevated liver enzymes, bile acids, or there is a new onset of headache which is not responding to any medications. Okay? Preeclampsia with the severe features. Now there is no terminology like mild, moderate or severe. Preeclampsia should be termed as preeclampsia with severe features or without severe features. So with severe features, how does the patient present? The same thing as I said, systolic blood pressure of 160 mm Hg, diastolic of 110 mm Hg, or one or two admissions at least 4 hours apart. The same thing again, thrombocytopenia, impaired liver function test, renal insufficiency. There can be even pulmonary edema and the same new onset of headache. Okay. This is one of the most commonest complication underdiagnosed, where the patient presents with hemolysis, elevated liver enzymes and low platelet count as a syndrome. This presents as a HELP syndrome, which is a very complicated one, which is associated with increased risk, very high morbidity and mortality of the patients. Okay? So there are different benchmarks are proposed. These are the few criteria to support this. Even the lactate LH elevated to 600 integration units per ml or more, AST ALT elevated more than twice of the normal, platelet count less than 1 lakh. These are the few criteria. And coming to the eclampsia, this is the convulsive disorder of the severe preeclampsia. Means the patient is manifested with the new onset tonic-clonic focal or multifocal seizures in the absence of other causative conditions like epilepsy and cerebral artery ischemia, infarction, intracranial hemorrhage or any drug use. Okay? Rule out criteria. There can be even epilepsy patient taking the same tonic-clonic conversion. So we have to rule out what condition it is. So some of these alternative diagnosis may be likely if new onset seizures occur after 48 to 72 hours postpartum, or when seizures occur during administration of magnesium sulfate. Even that also you have to. Coming to the investigations. Basic laboratory investigations for monitoring patients with hypertension pregnancy. First we put in mind about this health. Hemolysis, elevated liver enzymes, low platelet counts. Now again we go to hemoglobin and hemoglobin. Usually there is a hemoconcentration or hemodilution in hypertension patients. Usually it is hemoconcentration. The hemoconcentration supports diagnosis of the gestational hypertension with or without proteinuria. It indicates the severity. Levels may be low in very severe cases because of hemolysis. There can be less hemoconcentration due to hemolysis. Platelet count less than 1 lakh. This is showing the consumption of the platelets. Okay? Again, the levels correspond to the same, the severity, and with this level of severity we can predict the recovery period and all. Coming to the elevated. AST, ALT, elevated levels. When does AST, ALT get elevated? What is AST? Aspartate transaminase. ALT, alanine aminotransferase, which are the liver enzymes released from the hepatocytes. These are the These levels indicate the damage of the hepatocytes. Gamma glutamate transferase and alkaline phosphatase, when they get elevated, they indicate the hepatic cholestasis. Okay? They represent the hepatic cholestasis. These are the liver enzymes. See here, you can see the non-pregnant, pregnant, first trimester, how the levels are. Okay? When the levels double these, the normal levels, then you should be suspecting the liver injury. Okay? This is the gamma glutamate transferase, alkaline phosphatase. Though these are not very specific, but they indicate the cholestatic and the ongoing liver injury. Okay? Even we see the albumin bile acid levels also. Coming to LDH. LDH levels. What is LDH? LDH is an intracellular enzyme. It is used in the glucose metabolism, where the lactate is converted to pyruvic acid in the glucose metabolism. So it is within the cell. Once the cell ruptures, normal cell, any cell, body no, and the cells will all cells need glucose for their metabolism. So in every cell it is present. When it comes into the blood, when the levels rise, when there is a cellular damage, or when there is a increased cell membrane permeability in conditions like preeclampsia, infections, other damages, muscle injuries and all. Okay? So normal levels are 600 or less than 600. When the levels rise up to 600 to 800, we should suspect some pathology. Most commonly preeclampsia. This 800 LDH, it is an indicator that the patient is going into severe preeclampsia, and we are going to expect a fetal growth restriction and stillbirth also. Coming to the urine analysis. We take a dipstick test for proteinuria. There are both false and positive, negative tests also. So, negative dipstick results do not rule out proteinuria. First you should remember this also. Especially if diastolic BP is more than 90 ml. Proteinuria, 24-hour urine collection, is the standard to quantify proteinuria. Okay? If exceeding more than 2 grams per day, or if an excess of 3 grams per day, delivery should be considered. Spot PCR. This is a day in, day out we are doing this. Whenever the spot PCR levels are less than 30, okay, significant value is more than 30 or 0.3. Ratio is 0.3 we consider for as a high risk and we plan for termination. Okay. RFT, the serum uric acid. These levels, normal levels in early pregnancy are 3 mg per deciliter and late pregnancy 4 to 5 mg per deciliter. The levels increase because of fetal contribution of production of fetal uric acid also in the later pregnancies. This serum creatinine level in normal pregnancy usually not because of hemodilution, but in abnormal levels like in preeclampsia and all, it raises more than 1 mg per deciliter. Okay. These are the important angiogenic and anti-angiogenic because these are used for prediction of the preeclampsia onset. But also we should keep in mind these tests are available for the prediction. Angiogenic, antiogenic markers we are advising to the patient. If their levels are rising, we should think that in 4 to 5 weeks she is about to develop preeclampsia. That is the most importance of this angiogenic and anti-angiogenic markers. They are classified like growth factor. The normal levels are more than 100. If there are low VIGF levels, patient is more prone to develop the preeclampsia and the stillbirth. This is one of the other serum FMS like tyrosine kinase 1, which is a soluble receptor for vascular endothelial growth factor and placental growth factor. Usually the levels are 1000 and 2000. Elevated level suggests that there is increasing severity of hypertension. So if the ratio, still SFLT and PLPF ratio is more significant in assessment. If the levels are more than 38, then it is a low risk for preeclampsia. Less than. If it is more than 38 to 85, there is a medium risk. If there is a more, it is more than 85, it is a high risk for preeclampsia. This is one more soluble endogenic levels. These are also measured for 14 to 18 weeks. Other tests are like PAP-A. Here, this is also important. PAP-A is produced by the placenta. It is a marker as a part of combined pregnancy screening test, which is advised at 11 to 14 weeks. Low levels can indicate that placenta is not functioning and can be associated with adverse pregnancy outcomes. So, protomic time, as we advised, we are PT measuring the coagulation pathway, APTT, we are measuring this. So, normal levels 60 to 70 seconds, PT, APTT 30 to 40 seconds. If heparin intake is there, these are the higher normal levels. Okay? These are the secondary causes of, other secondary causes of hypertension in pregnancy. I will not take much time, I will just read out. We can see even in the obstructive sleep apnea where there is a high BMI, snoring and apneas during sleep. These investigations are advised. Overhead polysomnography, renovascular diseases like renal artery stenosis, renal parenchyma diseases, primary aldosteronism, hyperthyroids, hypothyroids, pheochromocytoma. So it is last, it is not least. It is very dreadful and it is very difficult to diagnose too. We have to have that thought. How the patient presents with, she presents with headache, palpitations, diaphosis, pallor and the labile bleeding. So we are measuring her plasma metanephris, urinary metanephris and catecholamines. How we are assessing? We look for the imaging of the adrenals and the metanephritis. This is a multidisciplinary management if the patient is a pheochromocytoma. There are other conditions like Cushing syndrome, hypercalcemia. There are other conditions like coagulation of the aorta and other drug uses. Coagulation of aorta and drugs. These are also they present with hypertension. Thank you.